Welcome to the deep dive. Today, we're getting into something that causes a lot of stress in facial trauma. Frontal sinus fractures. High stakes, high velocity.
Absolutely. And it's not just about looks, is it? It's about maintaining that crucial barrier between the airway and the brain.
Exactly. So we're diving into a management algorithm from Yavuser and colleagues. It's based on a lot of experience.
Right. Our aim here is to really pull out the clinical gold, the practical stuff, those decision points, the technical pearls that help you decide, do we preserve this sinus or do we obliterate? That's the big question for residents and attendings alike.
Okay, let's start with the basics. Incidence, we're looking at, what, 5 to 15% of maxillofacial fractures?
Somewhere in that range, yeah. But the really telling part is the mechanism. It's almost always high-velocity trauma. Think motor vehicle accidents.
And that immediately signals trouble, doesn't it? High energy means looking for other injuries.
You got it. That kind of force means about 3/4 of these patients have associated orbital, nasal, maybe other mid-face fractures too. And, it's critical to remember about 20% might be unconscious on arrival.
Wow, okay.
And another 20% could have a CSF leak right off the bat. So you're dealing with system-wide issues before you even focus on the fracture itself.
So mechanism tells us the risk. What about the anatomy? Why is the frontal sinus so tricky?
Well, it's about the walls. The anterior wall, surprisingly, is pretty tough. It's cancellous bone, can take 400 to maybe 1,000 kilos of force.
Okay.
But the posterior wall, much thinner. And it's right up against the anterior cranial fossa. So any displacement there risks hitting the dura, maybe even the frontal lobes.
Makes sense, but there's that other risk, the infection risk, even if the posterior wall looks okay.
Ah, yes, the foramen overshed. You're right. People sometimes overlook these. They're tiny venous channels connecting the sinus lining deep down to the subdural venous system.
So a direct pathway for bugs.
Essentially, yes. It means you can potentially get meningitis or a brain abscess even without an obvious posterior wall break. It just raises the stakes considerably compared to other facial fractures.
Definitely something to keep in mind. All right, diagnosis. Thin section CT, axial, and coronal. That's the standard. Why are coronals so important?
It's the best view, preoperatively anyway, to see the frontonasal duct, the FND. And assessing that duct is, well, it's fundamental to the whole management plan.
And alongside imaging, we're checking for CSF leaks, halo test, beta-2 transferrin.
Correct. Standard workup. And protocol-wise, IV antibiotics are key. Ceftriaxone and metronidazole usually for 7 days.
Longer if there's a leak.
Yep, extend to 14 days if you've confirmed a CSF leak.
Yeah.
And the authors really lean towards early surgery, ideally getting in there within the first week.
Okay, let's get into the management algorithm itself. You said it boils down to 4 key factors.
That's right. It's about 1 is the anterior wall involved, 2, the posterior wall, 3 is their dural issue, and 4, crucially, what's the status of the frontonasal duct, the FND?
Let's take the anterior wall first. What's the pearl for residents if it's undisplaced?
Pearl number 1. If it's undisplaced and the FND is okay, and you've got to be sure about that FND part, check the coronals, be suspicious, then no surgery needed.
Just antibiotics and follow-up.
Exactly. 7 days of antibiotics, like we said, and then long-term follow-up. They recommend a control CT at 12 months.
Huh.
But if it's displaced, you need to fix it.
And that usually means a bicoronal flap.
Yeah, that gives you the exposure you need to really see everything and restore the contour properly.
What about hardware? The forehead skin is thin. Plates can sometimes be felt later.
Good point. You can use metal plates. But the authors, and I tend to agree, favor resorbable plating systems here.
Why is that? Just cosmesis.
That's part of it, avoiding palpable hardware. But maybe more importantly, resorbables don't cause artifact on follow-up CT scans. You need clear images long-term to watch for complications. Metal can obscure things.
Makes sense. Okay, let's talk about the FND, the frontonasal duct. You called it the obliteration trigger.
It really is the main switch. If the anterior wall is often about contour, the FND is about function and preventing long-term problems like mucopyocele. If that duct isn't working, you can't safely preserve the sinus.
How often is it actually injured?
Surprisingly often. The paper notes about 55% of all frontal sinus fractures involve the FND. So while your coronal CT gives clues, you really need to confirm its status intraoperatively. High index of suspicion is key.
And if it is injured?
Then obliteration is necessary. No functional drainage pathway means you have to eliminate the sinus cavity.
Right, obliteration. This is core board prep stuff. What's the sequence? The absolute must-do steps.
Okay, 3 key steps.
What?
1, complete mucosal removal. You have to be meticulous. curettes, maybe a high-speed burr, get everything out, especially deep in those foramina bruchette.
Every last bit.
Every last bit.
Nice.
2, plug the duct, occlude the FND itself, usually done with a pericranial graft harvested right there. Fibrin glue helps secure it, sometimes bone grafts.
Okay. Mucosa out, duct plugged then.
Then step 3, fill the sinus, obliterate the dead space.
Now, traditionally, people used fat grafts for that filling step, right?
Right.
But the paper criticizes that, Pearl 2.
Yeah, they're quite critical of autogenous fat. And for good reason. It's a non-vascularized graft. Studies show it resorbs significantly over time.
How much resorption are we talking?
Well, some studies show less than 20% of the fat volume remaining in over half the cases after just 2 years. That's not reliable when you need a permanent barrier, especially in a potentially contaminated field.
So a non-vascularized graft just isn't robust enough.
Exactly. It's vulnerable during that initial avascular period. You need something that lives, something resistant to infection.
Which brings us to the preferred technique in this algorithm, the galeal frontalis myofascial flap. Why is this better?
Because it's vascularized. It brings its own blood supply, based on the supraorbital or supratrochlear arteries. This makes it much more resistant to infection and maintains its volume long-term. It creates a reliable, living partition.
That makes sense. Is there a trick to harvesting it?
Yes, a nice pearl from the authors. If possible, harvest it from the uninjured side.
Why the uninjured side?
So you can leave the periosteum intact over the fractured anterior wall fragments on the injured side. That periosteum helps with the bone healing for the anterior wall reconstruction.
Ah, clever. Okay, so you rotate this vascularized flap into the sinus.
Okay.
But you still need to reconstruct the anterior wall, right? Put bone back.
Correct. You use the native fragments as possible or cranial bone grafts. But here's another crucial detail. Don't just slap the bone graft tightly over the flap.
Why not?
You need to deliberately leave a small defect, like a slit, at the edge of the bone graft where the flap's pedicle enters the sinus.
To avoid squashing the blood supply.
Precisely. You must avoid compressing that pedicle. Leaving that little gap ensures the flap stays vascularized and does its job long-term.
Got it. Okay, let's shift to the posterior wall. Always more concerning because of the brain proximity. What if it's non-displaced?
If it's not displaced and there's no FND injury and no CSF leak, then you just monitor. No surgery needed for the wall itself.
But what if there is a CSF leak with a non-displaced posterior wall fracture?
Then you start with a conservative management trial.
What does that involve, and how long do you try it?
It involves systemic antibiotics, strict bed rest, and keeping the head elevated 30 degrees. If the leak is still going after 4 days, they recommend considering spinal drainage.
And the cutoff point. When do you say conservative management failed?
The authors recommend sticking with non-operative management for up to 10 days. If the leak hasn't stopped by day 10, it's very unlikely to resolve on its own. At that point, surgery is indicated.
Okay, 10-day limit. What are the absolute indications for operating on the posterior wall?
Right, so a persistent CSF leak beyond those 10 days, any displaced fracture, significant comminution, an obvious dural tear seen on imaging, or if there's a concurrent FND injury requiring obliteration anyway.
And the surgery involves craniotomy and dural repair?
Yes. Usually a pericranial patch graft is used to repair the dura.
How do you confirm you've got a good seal intraoperatively?
Critical step. You place the patient in Trendelenburg position head down. Then you ask the anesthesia team to temporarily increase intracranial pressure, like with the Valsalva maneuver.
And you watch for leaks.
Exactly. If you see no CSF leakage under that stress, you can be confident you've achieved a watertight closure.
What about cranialization? Taking the whole posterior wall out. When does that come into play versus just obliterating with the flap?
Cranialization is a big move, removing the entire posterior wall, letting the brain expand into the sinus space. Pearl number 3 from the paper is that the authors rarely do this.
Really? Why not?
They reserve it mainly for cases with significant underlying neurosurgical issues, like severe brain injury requiring decompression anyway. For most isolated posterior wall problems needing intervention, they find the galeal flap obliteration provides that necessary barrier without the added morbidity of cranialization.
So flap obliteration is generally preferred unless there's a strong neurosurgical reason for cranialization.
That's their stance, yes.
All right. Let's talk complications and wrap up. These are tough injuries. What about long-term issues?
Follow-up is essential, definitely long-term. The paper suggests at least 5 years. With yearly CT scans, you're looking for early things like dural problems, but also late complications, drainage issues, mucopyocele formation, chronic headaches, contour problems.
And if you do get a late infection like pus in the sinus.
That's another situation where the vascularized galeal flap really shines. Even in managing those late infectious complications, its blood supply gives it a much better chance of clearing the infection compared to trying to manage infection around a non-vascularized graft.
We mentioned fibrin glue earlier. What's its exact role?
It's a useful tool, an adjunct. Good for helping secure that pericranial plug in the FND, maybe tacking down the galeal flap edges. Some suggest it might even have minor osteoinductive properties.
Oh, it's not structural.
No, definitely not. It doesn't replace plates for fixing the anterior wall bone fragments. It's glue, not scaffolding.
Okay, this has been incredibly detailed. Let's distill it down. What are the top 3 clinical takeaways for residents and attendings listening?
Okay, takeaway number 1, diagnosis. The status of the frontonasal duct, the FND, is the primary driver for deciding between preservation and obliteration. Use your coronal CTs and always maintain a high suspicion for FND injury.
Got it. FND is king. Number 2.
Number 2, obliteration technique. When you do need to obliterate because of FND injury or severe contamination, the vascularized galeal frontalis myofascial flap is the gold standard according to this algorithm. And remember that technical point about leaving the flip for the pedicle when reconstructing the anterior wall.
Vascularized tissue is key. Okay, and number 3.
Number 3, conservative management limits. For those non-displaced posterior wall fractures with a CSF leak, yes, try conservative management, head up, antibiotics, maybe spinal drain, but give it a firm 10-day limit. If the leak persists, it's time for surgery.
Excellent recap. It really highlights that balance between restoring form, preserving function where possible, and critically protecting the intracranial space.
Absolutely. And maybe a final thought to leave people with. They often say frontal sinus anatomy is as unique as a fingerprint.
Right, huge variation.
So looking ahead, how might the increasing use of preoperative 3D planning, maybe even patient-specific 3D printed implants, start to change how we approach the really complex anterior wall reconstructions? It could potentially streamline things quite a bit in the future. Makes you think.